Good morning. I'm Dr. Melinda Abad-Bencio, and I will be discussing to you cardiomyopathies and myocarditis. So, cardiomyopathy is a condition primarily involving the myocardium or the heart muscle. This accounts for 5 to 10% of heart failure. This is defined as disorders characterized by morphologically and functionally abnormal myocardium in the absence of any other disease that is sufficient by itself to cause the observed phenotype. It is classified based on etiology to primary and secondary. If the cause is unknown, it is a primary type, and if it's secondary to other systemic diseases, it is classified as the secondary type. Traditional classification of cardiomyopathies includes a triad of dilated, restrictive, and hypertrophic cardiomyopathy. So the three clinical classification of cardiomyopathies are shown in this table. So one is DCNP or dilated cardiomyopathy. In here, there is left and or right ventricular hypertrophy. There is impairment of systolic function. There is congestive heart failure, arrhythmias, and emboli. In restrictive cardiomyopathy, there is endomyocardial scarring or myocardial infiltration resulting in restriction to the left and or the right ventricular filling. For hypertrophic cardiomyopathy, there is a disproportionate left ventricular hypertrophy which typically involves the interventricular septum more than the free wall of the ventricle, with or without an intraventricular systolic pressure gradient. And usually, the left ventricular cavity is not dilated. So this is based on the World Health Organization classification of specific cardiomyopathies. This table now shows to us the etiologic classification of cardiomyopathy as to primary or secondary. In many cases, however, it is not possible to arrive at a specific etiologic diagnosis because there is an overlap, and thus it is often more desirable to classify the cardiomyopathies on the basis of differences in their pathophysiology and clinical presentation. But for you, you need to take a look in this table. You need to memorize what falls under the primary and secondary type of cardiomyopathies. So, for the major causes of dilated cardiomyopathy, we have the inflammatory myocarditis, including infectious causes such as the viruses, most commonly caused by the Coxsackie virus, also adenovirus, the HIV, and the hepatitis C. Parasites such as Trypanosoma cruzi, which causes Chagas disease, and others such as toxoplasmosis are included. Bacterial causes such as diphtheria, spirochetes such as Borrelia burgdorferi causing Lyme disease, rickettsia causing Q fever, and fungal infection with systemic infection. For the non-infectious causes, it includes granulomatous inflammatory disease such as sarcoidosis and giant cell myocarditis. Others include eosinophilic myocarditis, connective tissue disorders, collagen vascular diseases, and use of chemotherapeutic agents. Also included is transplant rejection. Toxins such as alcohol and catecholamines such as methamphetamine and cocaine, and chemotherapeutic agents commonly caused by anthracyclines such as doxorubicin and trastuzumab, which are usually used for breast cancer, are the common causes of dilated cardiomyopathy. Use of interferon and other therapeutic agents such as hydroxychloroquine and chloroquine can also cause dilated cardiomyopathy. Other causes are heavy metals such as lead and mercury and occupational exposure to hydrocarbons and arsenic. Metabolic causes such as nutritional deficiency in thiamine, selenium, and carnitine can also cause DCMP. Electrolyte deficiencies, endocrinopathy such as thyroid diseases, pheochromocytoma, and diabetes can cause metabolic dilated cardiomyopathy. Obesity and hemochromatosis were also reported. These are the familial causes of DCMP, and some overlap with non-dilated cardiomyopathy. There are idiopathic causes and miscellaneous causes such as peripartum cardiomyopathy. There is left ventricular non-compaction, wherein there are presence of trabeculations in the left ventricular wall. Tachycardia-related cardiomyopathy is also an established cause. So comparing the three based on 2D echo findings and symptomatology. So first, 5 parameters are seen on 2D echo. So for ejection fraction, the normal EF or the systolic function of the left ventricle is more than 55%. For dilated cardiomyopathy, it is usually less than 30% when symptoms are severe. For restrictive, it is around 25 to 50%, and for hypertrophic, usually the ejection fraction is increased to more than 60%. For the left ventricular diastolic dimension, the normal of which is less than 55 millimeters. For dilated cardiomyopathy, the LV cavity is dilated to more than 60 millimeters, while in restrictive, it is normal or maybe decreased, so it is less than 60 millimeters. For hypertrophic, the cavity is often small or decreased. And then let's take a look at the relative wall thickness of the left ventricle. For dilated, it is usually normal or decreased. For restrictive, it may be normal or increased. For hypertrophic, it is markedly increased. And then for the atrial size, it is increased in the 3 types of cardiomyopathy, but it is massively increased in restrictive cardiomyopathy. The dilatation of the left atrium in hypertrophic cardiomyopathy is related to elevated filling pressure. How about for the valvular regurgitation? In dilated cardiomyopathy, the valvular regurgitation is secondary to the annular dilatation, while for the hypertrophic, it is related to the valve-septum interaction, or what we call the systolic anterior motion of the mitral valve. So, for dilated cardiomyopathy, mitral regurgitation appears earlier during decompensation, and TR or tricuspid regurgitation only occurs when there is existent right ventricular dysfunction. In restrictive cardiomyopathy, frequently mitral and tricuspid regurgitation is frequent, but it is rarely severe. In hypertrophic, valvular regurgitation is only in the mitral valve. For the symptomatology, the first presenting symptoms of these 3 types of hypertrophic, restrictive, and dilated cardiomyopathy, all of them initially presents with exercise intolerance. However, in restrictive cardiomyopathy, right-sided heart failure symptoms may occur early in the disease. So there is fluid retention, which may be manifested by peripheral edema or neck vein distension. There may also be hepatojugular reflux or ascites. In hypertrophic cardiomyopathy, exercise intolerance may be combined with chest pain. The chest pain can be secondary to subendocardial ischemia. So for congestive symptoms, usually for dilated, left-sided heart failure occurs first. So it is more prominent to see pulmonary congestion than peripheral edema in dilated cardiomyopathy. But there is an exception. In young adults with dilated cardiomyopathy, there could be a prominent right-sided heart failure before the left. In restrictive, right often dominates, while in hypertrophic, it is usually left-sided congestion. For the arrhythmias, ventricular tachyarrhythmia is often seen in dilated and hypertrophic cardiomyopathy. Atrial fibrillation can be seen in all the three types of cardiomyopathy. Conduction block can be seen in Chagas disease, also in sarcoidosis and amyloidosis. So left-sided symptoms of pulmonary congestion includes there is dyspnea on exertion, there is orthopnea, there is paroxysmal nocturnal dyspnea, and right-sided symptoms include systemic venous congestion such as hepatic and abdominal distension, there is discomfort on bending, and then there is peripheral edema. So this diagram shows to us the normal and the three types of cardiomyopathy. So what we want to appreciate in this diagram is the left ventricle, the cavity, and the walls. So for the right upper picture, that is your normal left ventricle. And beside it is the dilated cardiomyopathy. As you can see, the LV cavity is dilated, but the walls are not thickened. In hypertrophic cardiomyopathy, the LV cavity is small and obliterated, but take a look at the walls of the left ventricle. It is markedly hypertrophied and disproportionate, meaning the interventricular septum is markedly hypertrophied as compared to the posterior wall of the left ventricle. Moving on to restrictive cardiomyopathy, the LV cavity is normal, while the walls may be normal or hypertrophied, but it is proportionate, meaning both the septum as well as the posterior wall of the LV can be hypertrophied. So for dilated cardiomyopathy, the left and or the right ventricular systolic pump function is impaired, which leads to progressive cardiac enlargement, which is the process called remodeling. Histologic examination reveals extensive areas of interstitial and perivascular fibrosis. There may be myocyte necrosis and cellular infiltration, which may be present but are not prominent. So in many cases, the cause is unknown or idiopathic. There are reversible forms of dilated cardiomyopathy, and these can be associated with alcohol abuse, with pregnancy, selenium deficiency, hypophosphatemia, hypocalcemia, thyroid disease, cocaine use, and chronic uncontrolled tachycardia. 20% of patients have familial forms of the disease, and systolic failure is more prominent than diastolic dysfunction. So this is in contrast to restrictive cardiomyopathy. In dilated cardiomyopathy, more prominent is the systolic failure. And in restrictive cardiomyopathy, the problem is diastolic dysfunction. Remember that. So for the pathophysiology of DCMP, there is toxin exposure or viral infection, followed by death of myocytes during initial injury, but some of them die later by programmed cell death or apoptosis. The surviving myocytes hypertrophy as a compensatory response. However, local and circulating factors stimulate deleterious response, causing dynamic remodeling of interstitial scaffolding. So for clinical evaluation, you must perform a thorough history and physical examination to identify cardiac and non-cardiac disorders. You should ask the patient for a detailed family history if any of their relatives has a history of heart failure, cardiomyopathy, skeletal myopathy, conduction disorders, tachyarrhythmias, and sudden cardiac death. On the personal social history, you must elicit alcohol abuse, use of illicit drugs, chemotherapy, or radiation therapy should be asked in the past medical history if there's history of malignancy. You should assess the functional capacity by asking the patient his or her ability to perform routine and desired activities. Also, you should assess the volume status of your patient. Is the patient volume overloaded? Is there presence of orthostatic hypotension? So you should check your blood pressure on sitting, lying down, and standing position. You should also compute for the body mass index. After your clinical evaluation, to confirm your diagnosis, you should request for ECG. You want to know if there is rhythm abnormality, or you want to take a look if there is chamber enlargement and ischemic changes. You request for chest x-ray also to check for chamber enlargement as well as presence of pulmonary congestion or edema. You want to also check the pulmonary vascular markings of your patient. And then, you need to request 2D echo with Doppler. What you want to see in the 2D echo with Doppler is the LV cavity size, so the left ventricular and diastolic diameter, and the relative wall thickness. You want also to know the systolic function as well as the wall motion. So, another laboratory test you might want to request is magnetic resonance imaging if you want to check for myocardial inflammation and fibrosis. Also, you need to request for blood chemistry, which includes electrolytes and fasting blood glucose. But if your patient is already diagnosed as diabetic, you need to request for glycosylated hemoglobin. You need to request for creatinine, blood urea nitrogen, liver function tests including albumin and total protein, lipid profile, also screen for thyroid pathology by requesting for thyroid stimulating hormone. Check for serum iron and transferrin saturation, urinalysis, cardiac panel which includes creatinine kinase isoforms, and cardiac troponin levels. Also, you need to request for CBC to check for your hemoglobin and hematocrit and white blood cell count with differential count, including eosinophils. Also, you want to check for your acute phase reactants such as erythrocyte sedimentation rate. If you are suspecting for a specific diagnosis, such as those secondary to a genetic disease, you need to request for DNA sequencing and a panel selection based on the phenotype. If you are entertaining a possible infectious cause, you need to request for titers for infection, including for acute viral infection, secondary to Coxsackie, echovirus, or influenza. You need to also check for HIV or for other infectious causes such as Chagas disease, Lyme's disease, and toxoplasmosis. So for patients complaining of angina who are possible candidates for intervention, you might want to request for cardiac catheterization with coronary angiogram. And for those who are um, suspected to be having active rheumatologic disease, you might request serologic test. So endomyocardial biopsy, including sample for electron microscopy when suspecting specific diagnosis is warranted. And screening for sleep disordered breathing. So again, comparing the three cardiomyopathy based on diagnostic tests. So for chest x-ray, for dilated cardiomyopathy, there is moderate to marked cardiac silhouette enlargement. There is pulmonary venous hypertension. For the restrictive, there is mild cardiac enlargement. And for hypertrophic, there is mild to moderate cardiac enlargement. ECG, both for dilated and hypertrophic, you can appreciate ST segment and T wave abnormalities. For restrictive, low voltage URS complex and presence of conduction defects. LVH can be appreciated in hypertrophic cardiomyopathy with presence of abnormal Q waves. Into the echo, again, what you will see is a dilated left ventricle with systolic dysfunction in DCMP, while on restrictive cardiomyopathy, there is an increased left ventricular wall thickness and a normal or mildly reduced systolic function. For hypertrophic cardiomyopathy, you will be able to see an asymmetric septal hypertrophy or ASH and SAM or the systolic anterior motion of the mitral valve. For radionuclide studies, you will appreciate left ventricular dilatation and dysfunction on radionuclide ventriculogram, while for restrictive, normal or mildly reduced systolic function, while on HCM, there is vigorous systolic function. For cardiac cath, same with echo, still with ventricular dilatation and dysfunction, but this time you can check for an elevated left and often right-sided feeling pressure. There is diminished cardiac output. For restrictive, same with DCMP, the left and right-sided feeling pressure may be elevated and normal or mildly reduced systolic function, vigorous systolic function, and dynamic LVOT obstruction for hypertrophic cardiomyopathy. Let's move on to right ventricular dysplasia. Right ventricular dysplasia is marked by progressive replacement of the RV wall with adipose tissue. Often, it is associated with ventricular arrhythmias and a variable clinical course. But sudden cardiac death is a constant threat. So catheter ablation is indicated for putative arrhythmia and insertion of an ICD. ICD is implantable cardioverter defibrillator which is warranted in patients with right ventricular dysplasia with ventricular arrhythmia. Clinical manifestations includes symptoms of left and right-sided congestive failure. There may be a vague chest pain. Unusually, there is typical angina pectoris, and if that's the case, this may suggest the presence of a concomitant ischemic heart disease. It might present with systemic embolism, stroke, and syncope. So on physical examination, these are the PE findings that you can appreciate. You need to request for the following laboratory examination. In chest X-ray, you will be able to see cardiomegaly and pulmonary venous hypertension, or there is interstitial or alveolar edema. On ECG, these are the findings that you will be able to appreciate. On echo and on ventriculogram, there is LV dilatation and systolic dysfunction. So on cardiac cath and coronary angiogram, elevated LVEDP, left atrial pressure, and pulmonary capillary wedge pressure. When there is already supervening RV failure, the RVEDP, right atrial pressure, as well as the central venous pressure are all elevated. During angiography, it reveals a dilated, diffusely hypokinetic LV, and there is presence of mitral regurgitation, while usually coronary angiograms reveal normal coronary arteries. So you are able to exclude ischemic cardiomyopathy in this case. For transvenous endomyocardial biopsy, this is helpful in the recognition of secondary cardiomyopathies such as myocardial infiltration with amyloid and acute myocarditis. So, for MRI, this is increasingly used for the diagnosis of myocarditis. So, the picture below is an MRI of a patient with myocarditis. It shows the typical mid-wall location shown by the arrow. It is pointed by the white arrow with blue borders, no? For the late gadolinium enhancement from cardiac inflammation and scarring. While transvenous endomyocardial biopsy, this is helpful in the recognition of secondary cardiomyopathies, such as myocardial infiltration of amyloid and of acute myocarditis. So the picture below, on your left, that is a histopathology of an endomyocardial biopsy of a patient with acute myocarditis. There is massive infiltration of mononuclear cells and occasional eosinophils, with associated clear myocyte damage. So later on, in the course of the disease, this will be extensively replaced by fibrosis, even if the inflammatory response can be suppressed. So apical Takotsubo cardiomyopathy is another um, type of dilated cardiomyopathy wherein it is also referred to as an apical ballooning syndrome or stress-induced cardiomyopathy. It is referred to as the apical ballooning syndrome because it typically involves the apical segments of the left ventricle. It is called stress-induced cardiomyopathy because it is usually secondary to an intense emotional or physical stress, usually occurring in older women. So, global ventricular dilatation with basal contraction forming the shape of a narrow-necked jar or in Japanese, it is known as takotsubo, hence the name takotsubo cardiomyopathy. It can present as pulmonary edema, acute pulmonary edema, hypotension, and chest pain with ECG changes mimicking an acute infarction. Treatment includes use of standard therapy for heart failure with restriction of salt and water, use of ACE inhibitors, diuretics, and digitalis. ARB can be substituted in patients who are ACE intolerant, and most ambulatory patients can benefit with the addition of beta blockers. So majority of the patients, particularly those over 55 years of age, die within 3 years of onset of symptoms. And in about a quarter of patients, spontaneous improvement or stabilization occurs. Death secondary to takotsubo is either due to congestive heart failure or may be secondary to ventricular arrhythmias, either tachy or bradyarrhythmia, and sudden cardiac death. Also, there is systemic embolization, which warrants the need for chronic anticoagulation. Immunosuppressive therapy can be used in patients with biopsy with evidence of myocardial inflammation, but with long-term evidence of efficacy is still lacking. So alcohol should be avoided primarily because of its cardiotoxic effects. Antiarrhythmic agents are best avoided because they can also be pro-arrhythmic and uh, are only reserved to treat symptomatic or serious arrhythmias. Insertion of an ICD is useful in patients with malignant arrhythmias, and you can consider cardiac transplantation for those with advanced disease or those who are refractory to medical therapy. Let's move on to alcoholic cardiomyopathy. So this is a major form of a secondary type of dilated cardiomyopathy. Less than 1/4 survive 3 years, and if there is total and permanent abstinence from alcohol, these might be a key to the treatment of alcoholic cardiomyopathy. A term, holiday heart syndrome, is a second presentation of alcohol cardiotoxicity. It typically appears after a drinking binge. So this consists of a recurrent supraventricular or ventricular tachyarrhythmias such as atrial fibrillation. It can be followed by atrial flutter or presence of premature ventricular depolarization. Next is peripartum cardiomyopathy. What I want you to remember for peripartum cardiomyopathy, it this type may occur from the last trimester of pregnancy, meaning from 7 to 9 months, or within 6 months after delivery. Cause is unknown, but patients are typically multiparous and over the age of 30. Very high mortality rate, around 25 to 50%. Prognosis appears to be closely related to whether the heart size returns to normal after the first episode of congestive heart failure. For those who recover, especially if cardiomegaly persists, it is encouraged to avoid further pregnancies. So you need to advise the patient to undergo permanent, what do you call this, permanent type of contraception such as bilateral tubal ligation. For neuromuscular diseases causing related cardiomyopathy, one is Duchenne's progressive muscular dystrophy. So this is a mutation in a gene that encodes a cardiac structural protein called the dystrophin gene, which leads to myocyte death. So the ECG finding is a tall R wave in V1 to V3 with an R to S ratio greater than 1. There is an associated deep Q waves in the limb and lateral precordial leads. So this results from the selective transmural necrosis of the posterobasal left ventricle and associated papillary muscle. For myotonic dystrophy, this is characterized by a variety of ECG abnormalities, especially of impulse formation and conduction disorders. So, overt clinical evidence of heart disease is uncommon for myotonic dystrophy. For limb girdle dystrophy and fascioscapulohumeral dystrophy, cardiac involvement is uncommon and seldom severe, although there are arrhythmias and conduction disturbances occasionally. For Friedreichs ataxia, this is manifested as an abnormal electrocardiographic or echocardiographic findings. For ECG findings, it commonly demonstrates ST segment and T wave abnormalities, and for echo, it may it demonstrates left ventricular hypertrophy with symmetric or asymmetric hypertrophy of the LV interventricular septum compared to the free wall. So it could present Friedreich's ataxia can present as a dilated cardiomyopathy or a restrictive cardiomyopathy. For cardiomyopathy secondary to drugs, this is usually the chemotherapeutic agents used for the treatment of breast cancer. So, doxorubicin or adriamycin in high doses with a dose of 550 milligram per meter squared may produce fatal heart failure. Incidence of heart failure is related not only to the dose, because other risk factors such as irradiation, age of more than 70 years old, underlying heart disease, hypertension, and treatment with cyclophosphamide increases the frequency of cardiomyopathy by 8 to 10 fold. In ventriculography and echocardiogram, you can usually appreciate or you can use this to monitor the left ventricular function. So, to prevent doxorubicin-induced cardiomyopathy, you need to modify the dose schedule by giving the drug more slowly, along with selective use of cardioprotective agents such as the iron chelator dexamethasone, which are reported to have further reduced the risk of cardiotoxicity. You can also use or give your patients ACE inhibitors and diuretics aggressively, especially those who have demonstrated recovery of cardiac function. So, for another drug that can cause cardiomyopathy is use of cyclophosphamide in high doses. These may produce congestive heart failure acutely or within 2 weeks of administration. Histopathologic features includes myocardial edema and hemorrhagic necrosis. Also, 5-fluorouracil can produce ECG changes of myocardial ischemia or infarction. Cocaine abuse is associated with sudden death, myocarditis, dilated cardiomyopathy, and acute myocardial infarction, which results from coronary spasm and/or thrombosis with or without an underlying coronary artery stenosis. So, you need to take note of this: cocaine abuse producing acute myocardial infarction can be secondary to coronary spasm and/or thrombosis. Let's move on to hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy could be an idiopathic hypertrophic subaortic stenosis or a hypertrophic obstructive cardiomyopathy, or the HOCM. It occurs in about 1 in 500 of the general population. Two features of HCM: there is an asymmetric septal hypertrophy, meaning there is a preferential hypertrophy of the interventricular septum more than the posterior wall of the left ventricle, and usually it involves the apical septum. The second feature of HCM is a dynamic LV outflow tract pressure gradient. So there is an obstruction to the LV outflow, but it is dynamic, as opposed to which is seen in aortic stenosis. It is a fixed LVOT obstruction. So this is related to a narrowing of the subaortic area as a consequence of the mid-systolic apposition of the anterior mitral valve leaflet against the hypertrophied septum. This is what we call the systolic anterior motion of the anterior mitral valve leaflet. So this is a diagram of hypertrophic cardiomyopathy. So to orient you, this is the right atrium, right ventricle. This is the left atrium. This is the left ventricle. So this is the interatrial septum, and this is the interventricular septum. And you can see that the apical interventricular septum is hypertrophied markedly, and the anterior leaflet of the mitral valve presses into the interventricular septum. This one will now cause the dynamic LVOT obstruction or pressure gradient. So the pathophysiologic abnormality in HCM is diastolic dysfunction, which is characterized by an increased stiffness of the hypertrophied muscle. This results in elevated diastolic filling pressure and is present despite a hyperdynamic left ventricle. If you take a look histologically, there is a bizarre and disorganized arrangement of the myocardial cells along with a variable degree of fibrosis and thickening of the small intramural coronary arteries. In some children, the systolic compression of an intramyocardial segment of a coronary artery can lead to ischemia and eventually death. 50% of patients with HCM has a positive family history compatible with an autosomal dominant transmission. 40%, there is mutation of the cardiac B myosin heavy chain on chromosome 14. 50% is mutation of the cardiac troponin T gene on chromosome 1, and 20% is mutation of the myosin binding protein C on chromosome 11. 5% of HCM patients has mutation of the alpha tropomyosin gene and troponin I. So you need to memorize these genes. On 2D echo, about one-third of the first-degree relatives of patients with familial HCM have evidence of disease. Hence, it is warranted to request 2D echo as a screening tool for immediate family members of patients with hypertrophic cardiomyopathy. However, a single normal echocardiogram in a child does not exclude the presence of the disease. So for the hemodynamics, what you can see is a pressure gradient in patients with HCM, and this is dynamic and may change between examinations and even has a beat-to-beat variability. So these are the three basic mechanisms involved in the intensification of the dynamic pressure gradient: because of the increased LV contractility, because of decreased ventricular volume or decreased preload and decreased afterload. So you have to memorize this, no? What are the interventions that causes an increase in the gradient and the murmur of HCM? So exercise, sympathomimetic agents, and digitalis causes increase in the gradient and accentuate the murmur of HCM by increasing the myocardial contractility. Valsalva maneuver, sudden standing, use of nitrates, and tachycardia increases the gradient as well as the murmur, and this is because of the reduced ventricular volume. Conversely, or on the other hand, what are the things or maneuvers that can ameliorate or decrease the gradient and murmur? So if you elevate the arterial pressure by giving phenylephrine, by squatting, by sustained hand grip exercises, you elevate the arterial pressure and you will now decrease the gradient and the murmur of HCM. By increasing the ventricular volume, by increasing the venous return to the heart using passive leg raising, and if you increase the blood volume, you increase the gradient as well as action you decrease the gradient and the intensity of the murmur. So the clinical course of hypertrophic cardiomyopathy is highly variable. Unfortunately, in some patients, the first clinical manifestation of the disease is sudden cardiac death, often during or after physical exertion. You heard of these among very young, healthy athletes who suddenly suffered sudden cardiac death, and on post-mortem examination or an autopsy, the result showed hypertrophic cardiomyopathy. So the most common complaint is dyspnea. Dyspnea is secondary to the diastolic dysfunction. Other symptoms include angina pectoris, which is secondary to the subendocardial ischemia. There is fatigue, syncope, and near syncope, or what we call as graying out spells. So this is the PE findings for a patient with hypertrophic cardiomyopathy. The hallmark is a systolic murmur, harsh in character, diamond shape, meaning it's crescendo decrescendo, and usually begins well after the first heart sound. This is best heard at the lower left sternal border, radiating to the apex. The holosystolic blowing murmur is secondary to the mitral regurgitation that accompanies obstructive HCM. So after the clinical evaluation, we need to request for diagnostic tests such as ECG. So you can appreciate LVH with a widespread deep broad Q waves suggesting an old MI, the presence of atrial and ventricular arrhythmias during ambulatory Holter monitoring. On chest X-ray, it may be normal, but you can see a mild to moderate increase in cardiac silhouette. 2D echo is the mainstay in the diagnosis of HCM. So what you can see in the 2D echo is a left ventricular hypertrophy wherein the septum is 1.3 or more times the thickness of the posterior left ventricular free wall. There is also a ground glass appearance, and sometimes there is an associated systolic anterior motion of the mitral valve in patients with significant pressure gradients. The LV cavity is typically small or obliterated with a vigorous posterior wall motion but reduced septal excursion. So this is the 2D echo of a patient with hypertrophic cardiomyopathy. And as you can see, there is asymmetric septal hypertrophy, which primarily involves the apical and the midventricular interventricular septum. So there is also systolic anterior motion of the anterior mitral valve leaflet. The septum is hypertrophied more than the free wall of the left ventricle. The LV cavity remains normal or sometimes it is obliterated. Also, on histopath, you can see a disarrayed myocyte architecture with swirling and branching. One-fourth of patients with hypertrophic cardiomyopathy in Japan may present with apical hypertrophic cardiomyopathy. In here, this is a rare type of HCM that which involves the apical portion of the interventricular septum rather than the basal portion. So on ECG, you can appreciate a deep T-wave inversion in the precordial leads, and on 2D echo, there is a spade-like appearance with apical obliteration. So there is markedly hypertrophied apical septum. This is usually with a benign clinical course. So by requesting a radionuclide scintigraphy with thallium, this frequently reveals evidence of myocardial perfusion defects. And on cardiac cath, the two hemodynamic features is an elevated left ventricular diastolic pressure due to diminished LV compliance and a dynamic obstruction of the left ventricular outflow tract. Treatment. So, sudden death often occurs during or just after physical exertion, after a competitive sports, probably a very strenuous activity. You should avoid dehydration and use of diuretics should be with caution. What are the medications that you can give your patient? You can start your patient beta blockers to ameliorate angina pectoris and syncope in about one-third to one-half of patients. Amiodarone appears to be effective in reducing the frequency of supraventricular as well as fatal ventricular arrhythmias. Verapamil and diltiazem may reduce the stiffness of the ventricle, reduce the elevated diastolic pressure, and might increase exercise tolerance. So, in some instances, verapamil and diltiazem reduce the severity of the outflow tract pressure gradients. So, nifedipine should be avoided. And when beta blockers and calcium antagonists are used in combination, you should be cautious. And disopyramide has been used in some patients to reduce LV contractility and outflow pressure gradient. If atrial fibrillation occurs, a strenuous effort should be made to restore and then maintain sinus rhythm. You can put a dual chamber permanent pacing with a short PR interval. This is reported to improve symptoms and reduce outflow gradient in patients with severe symptoms by altering the pattern of ventricular depolarization and contraction. In some patients, they may benefit from septal ablation. So in here, there is ethanol injection into the interventricular septum causing infarction. So ethanol is injected into the septal artery, producing infarction of the septum. Insertion of ICD is Also recommended in patients who are survivors of cardiac arrest and for those patients who are high risk for ventricular tachyarrhythmias. Surgical myotomy or myectomy, this results in lasting symptomatic improvement in about three-quarters of severely symptomatic patients with large pressure gradients who are unresponsive to medications. So, what are the medications to be avoided? Digitalis, diuretics, vasodilators, nitrates, and beta agonists. Alcohol ingestion can produce sufficient vasodilatation, which will lead to exacerbation of the outflow pressure gradient, so it should be avoided. Again, first-degree relatives of patients with HCM should be screened by 2D echo. Prognosis, the natural history is variable. Atrial fibrillation is common, and its onset may lead to an increase in the symptoms. Infective endocarditis can occur in 10% of patients, and prophylaxis is indicated, particularly in patients with significant resting obstruction and presence of mitral regurgitation. Sudden death is the major cause of mortality in patients with HCM. These five criteria or parameters are the predictors of sudden cardiac death in HCM. Very young, aging less than 30 years, presence of ventricular tachycardia on ambulatory monitoring, there is a marked ventricular hypertrophy, syncope, especially in children, and those with genetic mutations associated with an increased risk of family history of sudden cardiac death. So there is no direct correlation between the risk of sudden cardiac death and the severity of symptoms or the presence or the severity of an outflow tract pressure gradient. So these are the only 5 predictors of sudden death. So this is the risk factors for sudden cardiac death in hypertrophic cardiomyopathy. It is just presented in the table. So an LV thickness more than 30 millimeters is present about 10% of patients, but many sudden cardiac death can also occur with wall thickness of less than 30 millimeters. So, ito din yun. This is the same with these 5 predictors. So, this is the algorithm for the management of patients with hypertrophic cardiomyopathy. So, depending on the presence and severity of the symptoms and the presence of an intraventricular gradient with obstruction to flow. So, patients with diagnosed HCM, you need to evaluate the risk for sudden cardiac death. If the risk is very high for SCD, consider implanting an ICD. If the risk is low, you have to do serial evaluation. If the patient is symptomatic, you can titrate beta blockers or calcium channel blockers. And if the symptoms are persistent, you check for the outflow gradient. If it's not significant, you can reevaluate the cause of symptoms if there is no evidence of severe progressive LV dysfunction. But if there is a severe progressive LV dysfunction, the patient is a candidate for cardiac transplantation. If the outflow gradient is significant and severe, you can try giving disopyramide or amiodarone. But if the symptoms is severe and refractory, you consider the patient for septal ablation or mitral surgery. Let's go to the last type of cardiomyopathy, which is the restrictive cardiomyopathy. The hallmark of restrictive cardiomyopathy is an abnormal diastolic function. So there is myocardial fibrosis, hypertrophy, or infiltration. But some patients with restrictive cardiomyopathy may show also some impairment of the systolic function. So myocardial involvement with amyloid is a common cause of a secondary restrictive cardiomyopathy. Other causes includes hemochromatosis, glycogen deposition, endomyocardial fibrosis, sarcoidosis, Fabry's disease, eosinophilias, and scleroderma. It is also seen in transplant rejection or patients who underwent mediastinal irradiation and for those with neoplastic infiltration and myocardial fibrosis. So this is a table of the different causes of restrictive cardiomyopathies classified into infiltrative, storage, fibrotic, endomyocardial, those with overlap with other types of cardiomyopathies, and idiopathic. So thromboembolic complications can ensue in about a third of patients. The most prominent symptoms are exercise intolerance and dyspnea, but most patients commonly have elevated venous pressure or right-sided symptoms. They have dependent edema, ascites, and an enlarged tender and pulsatile liver. There is elevated JVP, which does not fall normally or may rise with inspiration. That is what we call Kussmaul sign. Heart sounds may be distant, and there is S3 and S4. On ECG, this is the finding, a low voltage non-specific SCTO changes with various arrhythmias. On 2D echo, there is symmetrically thickened LV walls with normal or slightly reduced ventricular volume and systolic function. For Doppler, there is an accentuated early diastolic feeling. On cardiac cath, what we can see is a decreased cardiac output and an elevated right and left ventricular and diastolic pressure. There is a deep and plateau configuration of the diastolic ventricular pressure. So, the challenge in the diagnosis of restrictive cardiomyopathy is to differentiate it from constrictive pericarditis, and this is very challenging. We need to differentiate the two because constrictive pericarditis is potentially curable by operation. So, by right ventricular transvenous endomyocardial biopsy, you can see or reveal a myocardial infiltration or fibrosis in restrictive cardiomyopathy. While in CT or MR imaging, you will demonstrate a thickened pericardium, which is seen in constrictive pericarditis. So, those are the things that you can differentiate restrictive cardiomyopathy from constrictive pericarditis. The treatment for restrictive cardiomyopathy is usually disappointing, except for hemochromatosis, wherein it is responsive to desferoxamine by reducing myocardial iron content. Chronic anticoagulation is also indicated to reduce the risk of embolization from the heart. So for endomyocardial fibrosis, this occurs most commonly in children and young adults. This is usually seen in the African regions such as Uganda and Nigeria. So this is characterized by fibrous endocardial lesions of the inflow portion of the RV and LV, or both ventricles. This often involves the atrioventricular valves, producing a secondary valvular regurgitation. So the apex of the ventricles may be obliterated by a mass of thrombus and fibrous tissue. Medical treatment is often disappointing, and the surgical excision of the fibrotic endocardium and replacement of the involved AV valve have led to substantial symptomatic improvement in some patients. Next is eosinophilic endomyocardial disease. So this is also known as Loeffler's endocarditis and fibroblastic endocarditis. So the endocardium of either or both ventricles is markedly thickened with involvement of the underlying myocardium. There is a large mural thrombus on either ventricle. There is hepatosplenomegaly and the localized eosinophilic infiltration of other organs. Management includes use of diuretics, afterload reducing agents, and anticoagulation. Use of glucocorticoids and cytotoxic drugs, particularly hydroxyurea, appears to have improved survival substantially. Surgical treatment may be helpful in selected patients. So for infiltrative diseases, meaning the infiltration in between the myocytes, includes primary amyloidosis. So it is diagnosed by aspiration of abdominal fat or biopsy in the rectal mucosa, gingiva, liver, kidney, or myocardium to be made before death in over 3/4 of cases. The heart is typically firm, rubby, and non-compliant. So there are four clinical presentations. As seen in restrictive cardiomyopathy, there is diastolic dysfunction, or in combination with systolic dysfunction, presence of arrhythmias and conduction disturbances, and orthostatic hypotension. On 2D echo, you will appreciate a distinctive speckled appearance. So you have to remember this. Distinctive speckled appearance on 2D echo is characteristic of primary amyloidosis. So chemotherapy, often with alkylating agents, can increase survival, but the overall prognosis is poor. So this is the histopathology of a patient with primary amyloidosis. As you can see, there is infiltration of amyloid in between the myocytes. Next is hemochromatosis. Hemochromatosis can cause also restrictive cardiomyopathy, which is often a result of multiple blood transfusion or in a patient with hemoglobinopathy. It is an autosomal recessive form in the setting of DM, hepatic cirrhosis, and increased skin pigmentation. Diagnosis is confirmed by biopsy of the endomyocardium. Phlebotomy may be of some benefit if employed early in the course of the disease. But the treatment lies on the administration of deferoxamine subcutaneously, which reduce body iron stores and will result in clinical improvement. Next is myocardial sarcoidosis. So there is infiltration of the myocardium by sarcoid granulomas. This can produce a variety of arrhythmias, including high-grade AV blocks. There is right heart overload due to pulmonary artery hypertension as a result of parenchymal pulmonary involvement. So it does not only involve the myocardium, but also the lung parenchyma as well, which will now cause pulmonary artery hypertension and eventually right-sided heart failure. So for carcinoid syndrome, this results in endocardial fibrosis and stenosis and or regurgitation of the tricuspid and or the pulmonary valve. So for carcinoid syndrome, it involves the right-sided valves, the tricuspid and the pulmonary valve. Morphologically similar lesions have been seen with the use of anorexic agents such as fenfluramine and phentermine. After the cardiomyopathy, Let's now proceed on the second part of this lecture, which is myocarditis. Myocarditis results from the cardiac inflammation, which is most commonly result of an infectious process. Aside from infectious process, it may also result from hypersensitivity to drugs, or it may be caused by radiation, chemicals, or physical agents. A known number of cases, acute myocarditis progresses to chronic dilated cardiomyopathy. So the number of cases is unknown. Most commonly caused by viruses, especially the Coxsackie virus B. Clinical manifestations range from an asymptomatic state, inferred only by the finding of a transient STT wave abnormalities on ECG, to a fulminant course with arrhythmias, heart failure, and eventually death. This may simulate acute myocardial infarction also, presenting with chest pain, ECG abnormalities, and an elevated serum levels of myocardial enzymes. Physical examination is often normal, although in severe cases, you can appreciate a muffled S1 along with an S3 and the murmur of mitral regurgitation. Pericardial friction rub can be audible in patients with myopericarditis. So first type of myocarditis is the most common, which is viral myocarditis. Often, this is self-limited and without sequelae, but occasionally it can progress to a chronic form and to a dilated cardiomyopathy. There is a history of preceding upper respiratory tract infection with fever and flu-like illness, such as viral tonsillitis and nasopharyngitis. On endomyocardial biopsy, this may show round cell infiltration and necrosis of the adjacent myocytes. It is important that strenuous activity should be avoided until the ECG has returned to normal. For those patients that presents with congestive heart failure, they should be given ACE inhibitors, diuretics, and salt restriction. Some may appear to be unusually sensitive to digoxin. Deaths secondary to viral myocarditis is attributed to heart failure, to tachyarrhythmias, and heart block. Next cause of myocarditis is secondary to the human immunodeficiency virus, many of which have subclinical cardiac involvement. Some might present with pericardial effusion, others with pulmonary hypertension and neoplastic involvement. There is LV dysfunction in 1 to 2% of HIV patients. This is because of the infiltration of the myocardium by the virus itself or secondary to the opportunistic infection common in AIDS, such as toxoplasmosis. Antiviral drugs used to treat chronic HIV can also cause cardiomyopathy, both directly or through hypersensitivity to the drug. Next is bacterial myocarditis. They can be secondary to staphylococcal infection or to enterococcus as a complication of bacterial endocarditis. Diphtheritic myocarditis develops in over 1/4 of patients with diphtheria, and this is one of the most serious complications of diphtheria. This is due to the liberation of a toxin that inhibits protein synthesis and leads to a dilated, flabby, hypocontractile heart. Conducting system is frequently involved. So we can see cardiomegaly and severe congestive heart failure, which typically appears after the first week of illness. Prompt therapy with antitoxin is crucial. Antibiotic therapy for diphtheria is indicated but is of less urgency. Next is Chagas disease. The etiologic agent for Chagas disease is Trypanosoma cruzi, which is transmitted by an insect vector causing extensive myocarditis. This becomes evident years after the initial infection, and this is common in Central and South America. 1% of infected individuals have an acute illness causing acute myocarditis. The acute phase is unrecognized with non-specific symptoms or occasionally with acute myocarditis and meningoencephalitis, while the chronic form, this is the silent stage, which progresses slowly from 10 to 30 years, causing dilatation of cardiac chambers. There is fibrosis and thinning of the ventricular wall, aneurysmal formation, especially LV apex, and formation of mural thrombus. These are the pathogenic mechanisms involved in Chagas disease. There is lysis of the myocyte, primary neuronal damage. Specific immune responses may recognize the parasite or the related antigen. This will now lead to chronic immune activation in the absence of detectable parasites. Eventually, there is autonomic dysfunction and microvascular damage. So, the rule is a chronic progressive heart failure associated with low survival. Electrocardiogram is abnormal, which will show a right bundle branch block and a left anterior hemi block, which may progress to a complete atrioventricular block. On 2D echo, there is a unique pattern of hypokinesis of the posterior left ventricular wall and a relatively preserved septal motion. Commonly seen are ventricular arrhythmias, and the cause of death is either intractable congestive heart failure or a fatal arrhythmia. Treatment is directed towards amelioration of congestive heart failure and arrhythmias, and a progressive conduction system disease and heart block may eventually require implantation of a permanent pacemaker. Anticoagulation to reduce the risk of thromboembolism, and medical therapy is often unsatisfactory. So prevention is better by institution of public health measures, particularly the use of insecticides to eliminate the vector. Moving on to giant cell myocarditis. This is diagnosed with the presence of multinucleated giant cells in the myocardium. It is a rapidly fatal congestive heart failure and arrhythmia in young to middle-aged adults. There is cardiac enlargement, ventricular thrombus, and a grossly visible serpiginous areas of myocardial necrosis in both the ventricles. There is microscopic evidence of giant cells with an extensive inflammatory infiltrate. The cause remains obscure and may occur in association with thymoma, SLE, and thyrotoxicosis. The treatment of choice for giant cell myocarditis is cardiac transplantation. Next is Lyme carditis. This is a cause of tick-borne spirochetes, commonly seen in the Northeast, Upper Midwest, and Pacific coastal regions of the United States during summer. 10% of patients develop symptomatic cardiac involvement during the acute phase of the disease. There could be AV nodal conduction abnormalities, which are common, which leads to syncope. Intravenous ceftriaxone or penicillin is the treatment, and in mild form of Lyme carditis, you can give oral amoxicillin or doxycycline. Temporary pacemaker may be needed for those with symptomatic heart block. So this is the end for the lecture. Thank you for listening.